So macrocytic, MCV greater than 100. We can further divide macrocytic into what? Into megaloblastic and non-megaloblastic. Right, megaloblastic, non-megaloblastic. Megaloblastic anemias. So this you recognize this basically by seeing let's say hypersegmented neutrophils, right? Hypersegmented neutrophils. Also, if MCV is greater than 110, right, it's likely megaloblastic. Yeah, non-megaloblastic, their MCV is usually greater than 100, but it's still less than 110, not severely elevated. And I won't see hyper-segmented neutrophils. Yeah. The mechanism of megaloblastic is what? Anything that impairs DNA synthesis, basically. Anything that impairs DNA synthesis. So that will lead to what? Nuclear cytoplasmic asynchrony. So the nucleus is growing slower than the cytoplasm is. So they'll be growing, the cells will be growing before they receive signal, right? From the nucleus to divide. Yeah, so they look very, very big. So DNA synthesis impairment is to nuclear cytoplasmic dissociation or asynchrony, and that leads to abnormally large red blood cells and inappropriate red blood cell production as well, or ineffective red blood cell production. So of course, my major differentials here would be B12 deficiency, B9 deficiency, and sideroblastic. No, um, what's the B12, B9, orotic aciduria. Right, orotic aciduria. For non-megaloblastic anemia, of course, I won't see hypersegmented neutrophils. MCV is usually less than 10. This is due to surface area to volume, right, ratio. If there's increased surface area to volume ratio. Basically, in these conditions, red blood cells have excess membrane. That's what it means. Red blood cells have excess membrane. They have too much cell membrane, more cell membrane than they should have, because either the splenic macrophages are not able, right, to kind of remove the excess membrane from red blood cells as they circulate through the spleen, or something else is going on, right? So, example conditions where you might see these will definitely be conditions like liver disease. Liver cirrhosis can cause macrocytic, non-megaloblastic anemia, asplenia, patients without either functional or anatomic asplenia. Yeah. Chronic alcohol use, yeah, can also cause this as well. So these, yeah, I think these are the differentials for non-megaloblastic macrocytic. So, right. How do you differentiate the megaloblastic from each other? Of course, the closest one will be B12 and B9, right? B12 and B9, they are close. Why they close? They both cause megaloblastic anemia, but they have a lot of differences. Other than that, they are so different from each other. Yeah. Probably they are also close because they are both water soluble, right? Vitamins, however, they have so many things that besides those two things, they're very, very different. B12 is from animal sources, right? For sure. And B12 is also high for exam because it undergoes a complex but interesting, right, absorption process in the gut, right from the mouth all the way to the terminal ileum. There's so many things that play a role, right, in B12 absorption. So from the salivary gland, which makes a R binder, to the stomach, which makes acid, parietal cells acid, and intrinsic factor from parietal cells, to the small intestine where we have pancreatic enzymes from the pancreas, play a role in also right a bit of absorption. All the way to the terminal ileum where we have the receptors for intrinsic factor B12 complex, which is where beta is going to be absorbed, and to the liver where beta is usually stored in the body. So you can see salivary gland pathologies, gastrectomy, pernicious anemia, destroying the paretal cells, or antibodies against intrinsic factors, pancreatic insufficiency, patients with terminal ileectomy, terminal ileitis like in Crohn's disease, parasitic colonization of the terminal ileum like the diphyllobothrum latum, the duct tapeworm. All those things can, as well even liver cirrhosis or liver failure, all those things can lead to B12 deficiency, right? So complex, right? But quite interesting. For another thing that separates B12 from B9, besides the source of food, animal sources, as well as how complex the absorption is that B12 also causes deficiency will cause neurologic manifestations because we need B12 for myelination of neurons to form myelin. So if B12 is deficient, there's going to be demyelination of certain tracts in the spinal cord, typically the dorsal column and the lateral corticospinal tract, and that will lead to subacute combined degeneration of the spinal cord. So we're going to see upper motor neuron manifestations as well as a loss of proprioception, vibration sense, position sense, and stuff. Patient with B12 deficiency, which I won't see in B9 deficiency, right? B9, on the other hand, is from green leafy vegetables, right? So patients that are strictly meat eaters don't eat enough vegetables, they may develop B9 deficiency. Patients that are strictly vegans or vegetarians, they don't eat animal sources of food, eat meat and co. They can develop B12 deficiency. B12 deficiency. For folate, folate is also absorbed where? It's absorbed in the jejunum, right? Not even duodenum, jejunum. That's where folate is absorbed. There's an enzyme there called conjugase enzyme, I believe. Yeah, conjugase. There's an enzyme in the jejunum called conjugase enzyme. It plays a major role in folate absorption, dietary folate absorption. So, of course, patients with malabsorption from maybe they've undergone significant gastric bypass surgery that is also bypassing the jejunum, or they've undergone, or they've undergone a small intestinal resection, significant resection in the jejunum. Yeah, all those things may lead to B9 or folate deficiency. Also, certain medications, phenytoin, valproic acid, right? Those drugs, they probably by inhibiting conjugase enzyme, right? They cause B9 deficiency. They're going to inhibit folate absorption in the genome. Alcohol use can cause folate deficiency. Alcohol inhibits folate absorption as well. Yeah, patients with chronic hemolysis. Yeah, because we have a limited store of B9 right, in the body, unlike B12 that is stored in the liver and it takes sometimes years. We have sometimes up to 5 to 9 years worth of B12 right in the liver. Probably everything is fine. So it takes years to develop B12 deficiency. B9 deficiency can take place within months or days because we don't have like a significant store right, of folate. So anything that increases the use of folate, pregnancy, cancer, yeah, chronic hemolysis like sickle cell disease, thalassemias, where there's increased red blood cell turnover, right, in the bone marrow. All those things can lead to B9 deficiency, folate deficiency. That's why if you see in a patient with sickle cell disease, we should normally have normal MCV. If that person has increased MCV, you suspecting that they now have folate deficiency. So you have to supplement right folate, not even B12, not be folate, because B12 takes years to develop, but folate more likely develop because we don't have like a large store right in the body like we do right for all those wanna keep in mind, and also noting the differences as well as presentation wise, folate doesn't cause right neurologic manifestation. Both B9 and B12 deficiency can cause atherosclerotic complications because they're important in what? In neutralizing homocysteine, right? Or metabolizing homocysteine. So if either of them is deficient, homocysteine accumulates in the blood, homocysteine anemia. And homocysteine is toxic, right? It's going to damage the endothelial cells, it's going to lead to atherosclerosis formation, and there's risk of like stroke, MI, right? Peripheral artery disability, right? In patients with severe significant, right? B12 or folate, right? Deficiency because of homocysteine anemia. Biochemically, another way to tell them apart would be by looking at methyl malonic acid. Methyl malonic acid, right? So besides, so both of them we have homocysteine anemia, of course, because of methionine synthase inactivity. Also, there's an enzyme that requires B12 as a cofactor called methylmalonyl mutase, methylmalonyl-CoA, right? Mutase enzyme which converts methylmalonic malonyl-CoA to succinyl-CoA. So in B12 deficiency, methylmalonyl-CoA mutase is not working well. Methylmalonyl-CoA will accumulate and become methylmalonic acid. So you're going to see that as well, methylmalonic aciduria in patient with acidemia and aciduria in patient with B12. But you are not going to see that in folate deficiency. So those we should know. So those ones definitely high yield, commonly tested. There's a congenital disorder called orotic aciduria, right? Orotic aciduria. So in orotic aciduria, it's when these people have deficiency in an enzyme in pyrimidine synthesis pathway, right? Yeah, pyrimidine synthesis pathway. So the pathway that makes CTT, TTT, sorry, CTP, right? TP, UTP. Yeah. So an example of an enzyme that will be deficient there would be what's the name? UMP synthase, right? UMP synthase or orotic acid reductase enzyme. Yeah, orotic acid reductase enzyme, UMP synthase enzyme. So if those enzymes are deficient, orotic acid is one of the intermediates in that pathway, right? So it's going to accumulate, it's going to be high in the blood and the urine. But remember, downstream of the deficiency, we don't have pyrimidines. If we don't have pyrimidines, right, there's no way to make DNA. Right? Without pyrimidines, we can't make DNA. We can make DNA, red blood cells can't proliferate properly. That leads to megaloblastic anemia. So how will you differentiate that from B12 and B9? First, since it's congenital, probably will present earlier. This is right in life, and since it's genetic, they might have like a family history as well. But more objectively, we're looking at what the urine and the blood. If I see high uric acid in the urine blood, right, then a patient has megaloblastic anemia, uric acid is high in the urine blood. It's gonna be orotic aciduria, most likely. Another way they can tell you there's uric acid in the urine is patient has what? Stones. The uric acid can form orotic crystals. They can precipitate as what? Stones in the kidneys and lead to what? Kidney stones and blood hematuria and colic abdominal pain and stuff like that. Yeah. So that may complicate uric aciduria. But basically, your labs will be key, right? For sure in this case. Or they give you a patient that has megaloblastic anemia and the patient does not respond to B12 and folate supplementation. Now, right, that rules out B12 and folate deficiency, right? You have to look at other things like uric aciduria, as well as there's a condition called myelodysplastic syndrome, which is like a pre-cancerous, right? It's a pre-leukemia syndrome where there's abnormal differentiation, abnormal maturation of myeloid cell lines. And in that case, we might see some megaloblasts in their blood, in their bone marrow, as well as some other abnormal cells, abnormal macrophages and co. And but those people too, you may think it's megaloblastic, but actually they won't respond to B12, they won't respond to B9. You won't see orotic acid in their urine, right? It's likely precancerous, right? In that case, yeah. So those are going to be things to keep in mind. And then we know the list on the right side already. I'm not going to mention much on them. You're going to see other pictures of alcohol use. Asplenia, you might see our jolly bodies on peripheral blood smear. Liver disease, for evidence of cirrhosis and whatnot, yeah, skill examination. So these are my major differentials